Hello, everybody. I'm so happy to be here today with Dr. Kathleen Capaccione, who's going to present her important work on evaluating the combined anti-cancer response to checkpoint inhibitor, immunotherapy, and FAP-targeted molecular radiotherapy in murine models of melanoma and lung cancer as part of our first Inflammation, Fibrosis, and Cancer Journal Club. Thank you so much for being here, Kathy, today to share with us your what you have accomplished in this paper.
Thank you so much for inviting me, Dr. Salvatore, and for starting this very important journal club. I think it's a really excellent idea to look at the connections among these three topics. And so I'm really excited and really honored to be able to give the first talk where we can sort of bring together different disciplines and hopefully sort of make some progress in the fight against all of these diseases, which I think we'll find over time have a common origin and maybe sort of addressed in similar ways. So today I'm here to talk about, as you said, my paper looking at FAP-targeted molecular radiotherapy in lung cancer and melanoma models. And so our first, the picture that I show here is just a picture of a mouse where we looked at the FAP-targeted imaging agent, FAPI-04, on PET imaging, and we can see that there was excellent uptake. And so I'm going to talk about this in a lot of detail when I talk about my paper, but this just is sort of the beginning of demonstrating the great potential that FAP and FAPI have in terms of cancer, in terms of identifying and treating cancer. So sort of to back things up, what is FAP, what is FAPI? And so we have to start the story with fibroblasts, which are really a very important player for many diseases, principally cancer, which is what I mostly study, but also in fibrosis of the lung, the liver, and many other types of organs. And so in this paper, what I'm showing here is just how in cancer, in a mouse model of pancreatic cancer, we see that in normal pancreas, podoplanin, which is a marker of fibroblasts, is expressed to a moderate degree, maybe a low to moderate degree. We see that in the first panel. But then as we get closer to the cancer, we see a really significant increase in the amount of fibroblasts as shown by podoplanin. And so this really indicates to us that it is this cancer-associated fibroblasts, or also known as the CAFs, C-A-F-S, that are really important in tumors. And so when we think about tumors, it's important to realize that it's not just the tumor cells. I think, if 20 years ago you would ask someone, what is a tumor comprised of, they would probably be saying something like, well, it's tumor cells. So thinking about a single cell that expanded, had a clonal expansion because there was a mutation that caused the cell to lose its normal checkpoint inhibitors and therefore, or its normal checkpoints, and therefore it was unable to undergo unrestricted cell growth. And so that was sort of the more traditional thinking. But as we've gone on to study tumors in much more detail and really looked at them at the microenvironmental, the cellular, molecular level, what we've realized is that there's many, many other cells that comprise the tumor and the tumor microenvironment that play a key role. And so many of the advances that we're seeing in oncology today, for example, the vast improvements we've seen in outcomes with checkpoint inhibitor immunotherapy are largely driven by the fact, by this recognition that it's really the immune cells within the cancer that are driving some of the progression and maintenance of these tumors. And so if we target those cells, we might get sort of a critical toehold in terms of treating the tumors. And so one way, as I said, to look at this is the immune cells that infiltrate the tumor. But another thing to look at is the fibroblasts. And fibroblasts are very important cells, as I said, in multiple types of pathological states. And so they're cells that provide support, both physical support and also cell signaling molecule support to the cancer cells and other cells in the microenvironment. And so by disrupting the fibroblasts, it's sort of hypothesized that we can make really good anti-cancer advances in terms of controlling the tumors and their growth. And as I'll show at the end of this, a corollary that people are now beginning to explore is whether or not targeting fibroblasts may actually be also useful for other types of disease, like pulmonary fibrosis, like cirrhosis, and like infarcts in the heart, which are also based on a fibrotic process, but are not cancer per se.
Amazing.
Thank you. So looking at actually targeting fibroblasts, we, a group from Germany, began the development of a series of molecules which ultimately became known as FAPI molecules, and it stands for fibroblast activation protein inhibitors. So they began with a backbone molecule that was based on a quinolone molecule, as we see here. And this molecule has multiple R groups that are attached to it. And what they did in order to develop this further for to use clinically, preclinically, and clinically, is that they substituted different molecules at the different R groups to generate a series. So through lead optimization, they generated a series of these molecules, and then they tested them first they tested them preclinically in mouse models, and then they looked at the binding characteristics, how the retention, and so different attributes of the molecule to see how well it could go to the FAP in fibroblast and stay in the FAP. And so FAP itself is a serine protease that is present in all fibroblasts. And so basically anytime that you're targeting FAP, you're targeting the fibroblasts. And so through this, through this series of testing, they advanced molecules, and they eventually found that FAPI2 and FAPI04 had the best overall binding characteristics. And so those were advanced to further testing and stages. And as we'll see as I continue through this presentation, although sort of FAPI04 and FAPI02 have taken off in the research that's being done on them, there's also a continued effort to progressively improve these molecules to further improve these characteristics, specifically tumor retention time, and also to develop molecules that can not only be bound to gallium ultimately for PET imaging, but can also be bound to FDG, which is an important progress in the field of nuclear medicine because it allows for the significant scaling up of the production of these tracers. And so just to give you an idea of how well this binds, we see here that with the FAPI02 molecule, there's really excellent binding. So using immunofluorescence, they demonstrated how well we can really see the fibroblasts.
Wow.
It's a beautiful picture. It really is exciting. And so, taking that as sort of exciting finding and not only just looking at it in preclinical models, but moving it into the clinic was a really important advance, because the idea that FAP and FAPI is ubiquitous in cancer gives the potential of really expanding PET imaging and also treatment. And so this really goes into the field of nuclear medicine and molecular imaging, where there's a great push now to look at theranostic agents, so agents that have a simultaneous PET imaging agent as well as a therapy ligand. So here we show, this was actually the SNMMI image of the year in 2018. And what they demonstrated, this is just a subset of what they did. They showed in 28 cancers how they showed PET images, so they showed FAPI PET images demonstrating excellent avidity toward tumors. And so what they demonstrated here not only was that it was at least equal to FDG PET for many of the cancers that are traditionally imaged using FDG PET, but that in cancers that are traditionally hard to image using FDG PET, for example, small intestinal cancer, as we see here, they could actually see the tumors very well.
All of that uptake represents tumor.
All the uptake represents tumor. And what's exciting about this, you can see, is that it's not just the primary site of disease, but it's the sites of metastatic disease. And so when you think of this, not just for imaging, this is very important for imaging because it demonstrates that we could potentially use this for staging, which may actually be better than traditional FDG PET imaging, but we could also use this potentially for theranostics, where traditional radiotherapies have been a beam that targets the tumor directly, and usually it's the primary site or an oligometastatic site. But here, because the FAPI molecule will bind to the FAP in all sites that there are fibroblasts, which is nearly all sites of disease, it means that any targeted radionuclide that we send will go to all the metastatic sites. So now we're looking at really targeting a much larger portion of the disease than had been previously possible with external beam radiotherapy. So this was a very exciting advance and has continued to be very important in the field. And so just wanted to show that, there's excellent concordance. Other people have followed up on FAP PET imaging and how it correlates with sort of standard of care. So a recent paper in Radiology looked at FAP PET imaging for breast cancer and how it correlated with the MRI scans of patients. So this was just a sampling of the patients that they imaged, and you can see the very excellent uptake of the FAPIO4 in the breast tumors. But we also see, as I said before, is this really excellent imaging of the sites of metastatic disease. And so this could really be helpful for staging. The paper also demonstrated that there was excellent concordance between sites of breast cancer on MRI with the PET images. And so that really shows that it could be a very strong clinical PET agent for breast cancer, as well as many of the other types of cancer, as they showed in the prior paper. So this was very, very exciting and has been something that's really become a big targeting fibroblasts through FAP has been a very huge sort of effort now in the field of molecular imaging and molecular radiotherapy. And there have also been many other groups that have begun to develop these agents. So we've talked about the FAPI agents, but there's also other base molecules that have continued to be developed and now are commercially and in clinical trials. And so, as I mentioned before, theranostics is a very important aspect of this. And so the next sort of logical step was to look at whether FAPI, now we're on to 46, because it has improved tumor retention time, if that could potentially be an effective anti-cancer therapy. And so for those of you who are familiar with some of the currently available theranostic agents like Lutathera, lutetium, they also tried it with actinium, but lutetium is what I'm going to speak about in this paper, is a molecule that emits beta radiation and can have strong anti-cancer efficacy. And so they conjugated lutetium to FAPI46, and then they administered it in a murine model of pancreatic adenocarcinoma. What they demonstrated was that compared to tumors that were implanted in mice, you can see there's unmitigated cell growth in the untreated group. When they administered 30 megabecquerels of activity, they found a very significant reduction in the tumor growth over time. So it was a very, very important and exciting proof of concept that this could be used as an anti-cancer agent in pancreatic cancer. And, given the lack of really excellent therapeutic options for patients with pancreatic cancer, this is actually one of the clinical indications that some of the first clinical trials are investigating whether it could be potentially beneficial clinically. Also, difficult to treat cancers, including osteosarcoma and sarcoma, are on that list. And then some of the other groups are looking at sort of as a pan cancer, so enrolling patients not necessarily based on specific tumor types, but based on sort of broadly the fact that these tumors will all have fibroblasts as supporting cells for the cancer. So then this really led into my project. At the time that I began this project, this paper regarding pancreatic cancer had not actually come out. And so no one had published when I started on whether or not this could be used as a theranostic combination and whether or not it had anti-cancer efficacy. So it led into my paper where historically, my interest has been in lung cancer and novel treatments for lung cancer. So I wanted to investigate whether or not this FAP-targeted radiotherapy could be used as an effective anti-cancer agent, anti-lung cancer agent, I should say. And so furthermore, prior studies looking at targeted radiotherapy in melanoma using other targets, so not FAP, but other targets that are either melanoma specific or cancer specific, have demonstrated that when targeted radiotherapy is used in conjunction with checkpoint inhibitor immunotherapy, not only is the tumor growth attenuated, but there's actually regression of tumor growth over time. And so they also demonstrated in some of those papers that when the animal is then maintained and then rechallenged with tumors in a late stage, so at about 100 days after the initial inoculation of tumor, the animals actually resist rechallenge. And so that implied that there was some sort of immune memory that had been generated through the process of the combined checkpoint inhibitor immunotherapy and radiotherapy. And so because of that, we wanted to investigate in melanoma as well, whether or not, first of all, this could even work as a anti-cancer agent, and secondly, whether or not checkpoint inhibitor therapy could induce that tumor regression to see if we could make those tumors go away. So the design of the experiment basically was to take animals and inject them with 100,000 cells of either LLC1, which is the Lewis lung carcinoma cells, or B16F10, which is melanoma cells. Importantly, we did this in a syngenic model, and this is something that kind of differentiated our study from some of the other studies, because many people who work with animal models of different types of cancer, they'll use immunocompromised mice and then they'll implant human tumors in them. Much in the same way that humans can't accept an organ transplant from a non-human organism like a cow or a pig, mice with immunocompetent mice, so mice with a completely intact immune system, cannot accept tumors that are from humans. And so what these tumors were actually tumors that were derived from a mouse that had lung cancer and a mouse that had melanoma. And that allowed us to really study the immune system in a lot of detail, because the reaction that their immune system had to these tumors was mirroring, and also to the treatments for the tumors, closely mirrored what we would expect to see in our human patient population when they get a tumor and then are treated with these agents. And so we were able to sort of add that additional. We not only wanted to interrogate if these agents would be helpful, but also what was the mechanism underlying that. And so, as I said, we implanted tumors in the right subcutaneous tissue superficial to the shoulder. I had optimized it to ensure that the tumors would grow at an appropriate rate, such that they would be approximately 2 millimeters in greatest dimension at the end, at the pre-specified endpoint of the study, which was 21 days. And so we optimized our drugs such that the immunotherapy was administered 3 times. We used a combination of anti-CTLA-4 and anti-PD-1 immunotherapy, and gave them at day 12, 15, and 18, as was done in prior studies. And then we administered radiotherapy on day 13 at that 30 megabecquerel dose that was shown in prior work, the study I showed as well as others. So as I said, our pre-specified endpoint was day 21, where we euthanized the animals, and then we extracted the tumors to study them in greater detail. So during the course of the experiment, we measured and weighed the mice every 2 to 3 days. And these are the growth curves that demonstrate the measurement of the tumor in greatest dimension. This is the B16F10 cell line, so the melanoma cells. What we see here is that in the untreated mice, there was unmitigated growth of the tumor throughout the course of the experiment. In the immunotherapy treated mice and in the radiotherapy treated mice, both of those treatments resulted in a leveling off of the tumor growth over time. So they never reached the full growth that we saw in the untreated mice. So there was definitely an effect. But when we looked at the combined therapy group, similar to prior studies with other types of targeted radiotherapy, we saw that there was actually tumor regression in the combined group. And in many of the animals, in fact, all but one of the animals, there was complete regression of the tumor. So there was none left. There was just some residual tissue left there at day 21.
How amazing.
It was very exciting, very encouraging. We performed the same measurements on the lung cancer cells, tumors, and we found similar results, although not the same. What we found was that the untreated mice also had unmitigated growth throughout the course of the experiment, but the immunotherapy and radiotherapy treated mice had reduced tumor growth over time. The combined therapy group did not have tumor regression, but had a non-significantly different attenuation of tumor growth to the immunotherapy and radiotherapy treated animals. So this was our first sort of indication that these responses may be context and tumor type dependent. And so that was something we very much wanted to follow up on. Another note, which I'll talk about in the later slides, is probably has to do with how fast these tumor cells were replicating, but I'll talk about that in a little bit. So to further interrogate the mechanism of how this combined response to therapy actually, how it was affecting its anti-tumor effects, we wanted to study apoptotic cell death. So we looked at caspase-3 immunofluorescence because it's a part of the apoptotic pathway. And in both lung cancer and melanoma, we found that in untreated cells, there was no apoptotic cell death. And we see similarly in immunotherapy, there was a minimal caspase-3 staining, so minimal of that cell death. In the radiotherapy group, we start to see some of those positive cells. And then when we look at the combined group, we see that there's a statistically significant increase in the caspase-3 staining, indicating that there was a significant increase in the amount of apoptotic cell death.
And both for lung cancer and melanoma.
Exactly, both had the same effect. So we also wanted to study the Ki-67 immunofluorescence to see about how fast cell cycling was. And what we saw was that in melanoma and lung cancer, there was a significant amount of Ki-67 staining, so a significant amount of cell cycling occurring in those untreated samples. Now, I just want to point out how incredibly much staining there was in the lung cancer sample, which is why I hypothesized we didn't see a combined effect, just because it's such an aggressive tumor that we were studying, which we know from other experiments that we've done in the lab, that it may just not be able to sort of overcome the large amount of cell cycling and division and constant chronic progression. So that's something we definitely want to look further into in the future, if it really was that there was not a combined effect, because we see a combined effect in many of our assays evaluating this. It may just have been that the tumor was growing so fast, we lost that effect in the overall significant tumor progression. What we saw here was that when we gave immunotherapy and also radiotherapy, there was a significant decrease in the amount of cell cycling. And this was totally abrogated in the combined group. And so I kind of can explain a little bit of why we're seeing these tumors grow less over time. And so I quantitated these two sort of studies of immunofluorescence, and we can see that these differences are in fact significant. So the final thing that we wanted to do was evaluate the infiltrating cell populations within these tumors to identify if there were certain populations that were specifically responsible for these changes that we see in tumor growth and that were differing in the combined therapy treatment versus either therapy treatment alone. Because we wanted to understand, was this just sort of a stacking of the same response, or was this different responses that were some sort of different response that was occurring in the dual treated samples? So this was the flow gating strategy that we employed to investigate this problem. And so I'm not going to go through all of the results because there are many, but I just wanted to highlight some of the important and interesting cells that seem to change in this in our different samples. So here we're looking at the dendritic cell populations. We have dendritic cell lineage 1 and dendritic cell lineage 2 in melanoma and lung cancer. And this was interesting because in melanoma, there were significant differences, and in lung cancer, there were not. So already this is supporting our previous conjecture that there's a sort of dependence on the cell type, the cancer type. And so it implies that this whole system will need to be studied in each cancer individually. What we saw with dendritic cell lineage 1 was that there was a significant decrease between the untreated samples and the immunotherapy, radiotherapy, and dual treated samples. So that was interesting. We saw, though, that conversely, in dendritic cell lineage 2, there was an increase between the untreated, the immunotherapy, and radiotherapy treated samples. And so we see, though, that the dual treated sample sort of lands somewhere between the two. So this definitely requires further study to understand how these, what's causing these cell populations to change in the way that they do. Another important highlight from the results of this study was that the myeloid cell lineage cells seem to have very important changes that were also cell type and context dependent. So in looking at melanoma, we see that monocytes decreased in the dual treated samples significantly compared to the immunotherapy treated. And so that was an interesting result because it actually, the monocytes were increased in the immunotherapy alone treated sample. And so this clearly demonstrates that there's something different going on in the dual treated cell populations compared to either alone. In the M1 and M2 macrophages, we see similar decreases in the dual treated sample compared to the immunotherapy. In lung cancer, we see just the opposite. So in the monocytes M1 and M2 macrophages, we see that there's basically non-significant differences among the immunotherapy and radiotherapy treated samples, but that the dual treated samples have significant increases over all myeloid cell types. And so this is really interesting and implies that there's something going on there, that this is an important sort of cell lineage, and that we should really study this in more detail to see how it controls how these the sort of anti-cancer response in animals treated with these agents.
Mhm.
So the conclusions that we drew for this were that FAP-targeted radiotherapy is an effective anti-cancer agent against both lung cancer and melanoma. We found that combining FAP-targeted radiotherapy with immunomodulatory agents, at least in melanoma, has the potential to increase and possibly increase response and possibly generate a durable response. So it's a very important finding that we're excited to follow up on. And finally, that it's probably the changes in the tumor infiltrating cell populations that underpin this response. So the future directions, not just for us, but for FAP, fibroblast targeting and imaging in general, basically there's a lot of clinical trials underway now for both imaging and treatment of malignancies using FAP-targeted PET and then FAP-targeted molecular radiotherapy. As I mentioned before, they're sort of in the process of transitioning from gallium PET imaging, FAP PET imaging to FDG PET imaging, which is going to be an important advance in the field because it will allow us to really scale this up and make this available to people in the clinic very universally, as opposed to just being at centers that have a gallium generator and are able to make it on the spot and have a radiochemist to actually conjugate the molecule. And then more recently, as I kind of alluded to earlier, studies are looking into FAP imaging for other pathologies. And I think that's very interesting and sort of brings us full circle to this journal club, because people are recognizing the power of this modality and of this agent, not just in cancer, but in other types of fibrosis. And so this year I was lucky enough to attend SNMMI, and this was the SNMMI image of the year this year. FAP again was FAP for imaging myocardial infarction. So this group showed beautiful images of FAP PET imaging. For those of you who are cardiothoracic imagers, this might look unusual, the lungs and the heart, because this is a mouse, but not your typical CT scan, but what they were able to really show with, very elegantly how beautiful the FAP can sort of be retained in the scar of the myocardium after infarct. And then finally, very near and dear to our hearts, people are beginning to, groups are beginning to publish on and study the use of FAP PET imaging for fibrosis, for pulmonary fibrosis. And so they have some beautiful images they showed in their paper targeting FAP fibroblasts in pulmonary fibrosis. And you can just see the beautiful uptake in those areas and how well they correlate with the areas of fibrotic lung disease on the chest CT here and here. So that's very exciting, and I think something that's going to be coming out very soon. In more studies about it, and hopefully transition to sort of more broad clinical use. So with that, I would like to thank all of my mentors, Dr. Akiva Mintz, Mikhail Dobrovin, of course, Dr. Salvatore, my program directors, the RSNA, who I'm a grant recipient that sponsored this work, and the residency program here at Columbia, which I graduated from, which so graciously supported me in completing this work. So with that, I'd like to again thank Dr. Salvatore for the kind invitation to be a part of this journal club and have the opportunity to present my work here. And I'm happy to take any questions.
Thank you, Kathy. I have a few, what a beautiful presentation, and I can imagine all the implications of the work that you have accomplished. And just a few background questions. So what made you interested in this project? How did you decide to study FAP? Well, why is that important to you?
So as I sort of alluded to earlier, I'm sort of a lung cancer researcher at heart. So that was my original interest, basically finding new therapies for lung cancer. When I began this project, I was working in the molecular therapeutics and imaging laboratory at Columbia. We hadn't settled on FAP. To be honest, we were actually looking at another targeting molecule. But when FAP sort of came on the scene and I became aware of it, it just had such great potential. I mean, the images, I think, speak for themselves when you look at that picture of the 28 cancers. And at that time, no one was using it for therapy. They were only using it for imaging. And I thought, this is like an opportunity waiting to happen, right? Where if it looks this good on PET imaging, it's going to target those areas as well with this therapy. So, I spoke with our radiochemist. I spoke with Dr. Mintz, the director of the lab, and I said, can we do this? And he said, give it a try, sure, go ahead, give it a try, so it was wonderful. They supported me in kind of getting the molecule, helping, the radiochemist was able to conjugate it. We had to test it out, but it just seemed like an exciting opportunity. And I'm really grateful that I was able to kind of become part of it, because now FAP is almost like become a movement in theranostics, because people feel that it's going to actually replace FDG PET. It's somewhat of a matter of debate, but something that people feel. So it's very exciting to be working in a field that a lot of people are talking about and publishing on, and hopefully
There are challenges during the research project. Did you have any hurdles to overcome?
I think just optimizing a lot of these, just getting the tumors. For example, I was talking about how aggressive the lung cancer is, and I initially started out with using more of a tumor inoculum, which was more what I was used to. My prior studies, I had done a lot of work with xenografts using immunocompromised mice and human tumors. And so you need a lot more cells to get the tumor to take. So the first mouse had cancer like in 2 days, and it was, widely like wrapping around their body. So, just a lot of the optimization steps to get it to work right. And of course, handling the radiotherapy is always, a challenge, because you have to do everything in such sterile and careful techniques not to contaminate everything. But overall, I think I had wonderful support, and I think it was also a great opportunity to learn how to do these things. So.
What are you looking forward to in the future? What do you hope to work on next?
So I'm very excited about the potential for combining with other targeted therapies. I think that one of the very exciting therapies in lung cancer that is coming out, that has come out, is a KRAS inhibitor called sotorasib, and there's other KRAS inhibitors about to be approved sort of right on its tail. So adagrasib is the one that comes to mind, and these agents target KRAS, which was thought to be undruggable for many years. So now that they are there, and people have done studies on them showing that they also have immunomodulatory effects, I think it's really exciting, the opportunity to potentially combine this radiotherapy with that, and in melanoma, other targeted inhibitors that could potentially increase the efficacy of those responses.
Thank you, Kathy. It's been wonderful to get to meet with you today.
Thank you so much for taking the time to speak to me, Dr. Salvatore. I appreciate the invitation.
All the best.
Bye-bye.